We'll get started in just a moment. Thanks for everyone's patience. We will get started with our webinar in just a moment. Good afternoon. I'm so pleased to welcome everyone to our forum webinar today. My name is Colleen Berry, and I'm the chair of the Department of Health Policy and Management at the Johns Hopkins School of Public Health, and it's my great pleasure to co-chair the National Academy's Forum on Mental Health and Substance Use Disorders with Howard Goldman. This webinar is the first in a workshop series of 3 webinars hosted by our forum. The topic of the 3-part workshop is Mental Health and Substance Use Disorders in the Era of COVID-19, with a special focus on the impact of the pandemic on communities of color. Research has documented rapidly worsening mental health and substance use in the context of the pandemic, and the disproportionate impact of the pandemic on the health, mental health, and well-being of communities of color. We will begin exploring this issue today with our speakers. For the audience, please put your questions in the Q&A. This webinar lasts from 1 to 3, and the last 30 minutes today will be a question and answer period highlighting the questions posed by our audience, including some submitted in advance of our panel. Before I pass it over to my forum co-chair, Howard Goldman, to get us started, I wanted to highlight first our sponsors of the forum, who are listed on this slide. Without support from our sponsors, none of this work would be possible, and we're very grateful to them. The mission of our forum is to provide a structured environment and a neutral venue to discuss data, policies, practices, and systems of care that affect people with mental health and substance use disorders in the United States. Our statement of task and other information about the forum can be found on our website, which you can see in this link here on the slide. I'm pleased now to turn it over to my co-chair, Howard Goldman, to introduce our planning committee co-chairs and the full planning committee, and to kick off this workshop. Howard.
Thanks a lot, Colleen. I want to add your welcome to your welcome and say how grateful we are for our participants today. And we're glad we have a big audience to share their expertise with them. I wanted people to know that the event is archived and recorded at the link shown on the slide here. The materials related to the webinar, the slides, will all be available to people in case you want to check back or share them with colleagues. As Colleen said, not only do we have 4 really outstanding presentations, but at the end, we'll have a whole half hour devoted to questions and answers. You can use the Q&A function to express your question. Colleen will go through them and manage that session after we hear from our 4th speaker. It's my special privilege to thank the planning committee. These webinars take a lot of time and effort to organize. And the people whose names you see on the slide in front of you devoted many, many hours to talking about what we should focus on and how we should proceed. So it's my pleasure to thank the two co-chairs of the Planning Committee, Lark Wong, who's the Director of the Office of Behavioral Health Equity at SAMHSA, the Substance Abuse and Mental Health Services Administration, and Deidre Roach, who's a Medical Project Officer with the National Institute on Alcohol Abuse and Alcoholism in their Division of Treatment and Recovery Research. For Deidre, this is a return. She was the co-chair of our previous series of webinars, and I'm going to turn the floor over to her for further introductions. Deidre?
Well, thank you, Howard. And thank you again to everyone in our audience for joining us today. Due to the COVID pandemic, today's workshop is being held over a series of 3 webinars, with subsequent webinars scheduled to take place on Thursday, December 3rd and Monday, December 14th, from 1 o'clock to 3 o'clock p.m. Eastern Time. The COVID-19 pandemic has created both short-term and long-term negative consequences for behavioral health outcomes. The pandemic has also created, revealed, and exacerbated long-standing racial and ethnic disparities in behavioral health care. Today's first webinar will focus on how COVID-19 has revealed and exacerbated mental health and substance use disorders and highlight the impact of the pandemic on communities of color. The second webinar will focus on access to healthcare and delivery of services for people with mental health and substance use disorders, especially among racial and ethnic groups that have been historically underserved. The third webinar will explore the mental health well-being of the healthcare workforce, with a particular focus on the impact of the pandemic on people of color. A proceedings will be developed from the entire workshop and will be available on the National Academy's website within a few days after the final webinar. Without further ado, I'm delighted to welcome our distinguished speakers for today's first session, Dr. Joshua Gordon, Director of the National Institute of Mental Health, and Dr. Nora Volkow, Director of the National Institute on Drug Abuse, who will provide an overview of mental health and substance use disorders in the era of COVID-19, with a focus on the US general population. Full bios for Drs. Volkow and Gordon may be found in the briefing books located on the meeting webpage. Please join me in welcoming first Dr. Joshua Gordon.
Hi, well, thank you very much, Deirdre, for that kind introduction and welcome. And it's really my pleasure to be here today to really begin a discussion that, as you just heard, is going to take place over 3 days about the mental health impact of COVID-19, mental health and substance use impacts of COVID-19. It's a pleasure to be here along with my colleague, Dr. Volkow, and really looking forward to the discussion. I'm going to try to stay with you as much as I can for today. If I could have the next slide, please. So I'm going to talk to you about 3 things. I'm going to talk to you about what we know, which is some, but not a lot. And then what we know from previous experiences to inform our response to how to deal with what we know. And then talk about some questions for the future and resources we're bringing to bear on this. Next slide, please. What we know. Next slide. There's a few things we actually do know about the SARS-CoV-2 in infection and the mental health impacts. There are both direct and indirect impacts on mental health of the pandemic. I'm going to start with the direct one, partially because we have some data and partially because it's pretty straightforward, although I don't mean to say by straightforward, do I mean to say we have any answers about how to deal with it. There are bidirectional associations between COVID-19 infection itself and psychiatric disorders. Not shown in this slide is that if you have a psychiatric disorder, and I believe Nora will say the same thing about substance use, if you have a psychiatric disorder, you are at somewhat of an increased risk for developing COVID-19. Some of that is due to the congregate settings, such as prisons and other facilities that many individuals with serious mental illness are in. Part of it has to do with comorbidities that many people with serious mental illnesses have. We don't have all the answers. We know that there is a slight increased risk for COVID-19 if you have a mental illness. Shown here is the opposite, which is if you don't have a mental illness, but then contract COVID-19, you have an increased risk of developing a psychiatric disorder over the next few months. And that's shown here, 3 different slides. On the left, 3 different graphs. On the left, all psychiatric illness. In the middle, mood disorders. On the right, anxiety disorders. And you can see in the red lines that the risk of getting a diagnosis that you did not have before of disorders belonging to these overall, and then the 2 subclasses, is increased after COVID diagnosis over the ensuing 3 months, shown here, such that about 6% of all patients will have a new onset mental illness in the context of a COVID diagnosis. Overall, that means about 18% of people recovering from COVID in the ensuing 3 months will have a psychiatric diagnosis, including, of course, the larger group of people who had a pre-existing one. Now, we'll get back to what that means, but one thing we do see is evidence for increased risk of mental illness as a direct consequence of infection by COVID-19. Next slide, please. What else do we know? We know from a number of surveys, I'm showing just one here, of varying scientific rigor, perhaps the most rigorous one done by the CDC, again shown here, that all suggest an increase in the rate at which individuals from the general population are reporting symptoms corresponding to mental illnesses. This is not diagnoses, and these samples are more like samples of convenience than they are like true epidemiologic samples, but every single one done so far is showing an increase at the rate of self-report of symptoms of anxiety and depression, about 30%, as Nora will talk more about, starting or increased substance use, trauma or stress-related symptoms, and suicidal ideation, such that about 40% of US adults contacted in these surveys report struggling with one or more mental health or substance use symptom. This is probably something on the order of a doubling in the rates. And most concerning, as you've probably heard about in the press, are increases in the rates by which young people are reporting suicidal ideation. It's pretty tremendous, a 2- or 3-fold increase in the risk of an individual reporting suicidal ideation in the preceding 2 weeks in the context of the pandemic. Now, next slide. There are many potential reasons for this. One of which is the pandemic itself. One of which, if I actually, you could just punch through until the whole slide is shown. Yeah, that's good. One of which is the mitigation measures, of course, and another is the economic impacts. And we haven't yet been able to parse the impacts of these various contributing factors to that increase in mental health symptomatology. But one thing that is clear is that there was an immediate impact during the pandemic of the shutdowns on access to mental health care that has since rebounded. And this is shown here. The dotted line is 2020 visits, starting with the first week of the year, running through the 42nd week, which was just really a few weeks ago. And this data was published again in CDC's Morbidity and Mortality Weekly Report, showing that in March, which is you see the steep decline in the dotted line on the left-hand graph, there was a dramatic drop-off in mental health-related emergency department visits. And this is for the pediatric population, but this is also true for the adult population. What you see is a slow rebound back to something close to pre-pandemic levels of emergency room visits for mental health related reasons. So people are coming back into the ER to seek help right now. And on the right-hand graph is the proportion of those visits that to pediatric emergency rooms, proportion of all visits to pediatric emergency rooms that have a mental health related complaint. And what you can see in the dotted line is that there was a steeper drop-off for non-mental health related visits to the pediatric emergency rooms. And therefore a greater percentage of those were having to do with mental health. That could mean lots of different things. It could mean that mental health complaints requiring emergency room visits are actually increasing amongst the pediatric population, or it could be that the other health related complaints are decreasing, or it could be that people are more attuned to these mental health related issues. It's really hard to tell at this point. Next slide. What about suicides? I told you suicidal ideation is increased in some of these surveys. Are we seeing an increase in suicide attempts or suicide deaths? And so far, the answer is no, although, again, it can be hard to puzzle it out. This data comes courtesy of Greg Simon, who runs our Mental Health Research Network, which is a network of healthcare management organizations with something like 20 some odd million people under care. Each line here represents a single healthcare system. They're of different sizes, and the y-axis is absolute number of visits to these healthcare systems for self-harm diagnoses, either a suicide attempt or a self-injurious behavior. And what you can see is that those numbers have remained fairly steady as we go from 2019 on the left side through to 2020. The drop-offs from June to September are simply because it takes a long time to get these diagnoses actually into the system where the MHRN can count them. So really, it's only accurate up through about June. But what you can see is that these, in none of these systems are these self-harm diagnoses going up. That may mean stability, or it may mean because of the decreased number of visits, we're seeing, an actual increase in the population, but people are just not seeking care for it. Next slide. I should mention that in addition to that, there are some bioarchive reports that are not yet published, so I don't want to show the data, but that do suggest, at least in select states where they have been able to gather the data quickly enough, that there's been no increased risk in suicide deaths in the population at large through at least early summer. Again, that's preliminary data, and we don't really know the answer, but as you'll see in a moment, that may be something to be expected. So now I'm going to talk about, well, how can we put these data that we're getting from COVID-19 into context from what we know of prior emergencies, and how might that inform our response to these increased rates of symptoms? Next slide, please. So there's several things we know from previous disasters, mass traumas, and epidemics. Most people who are exposed to trauma improve with time. That said, most of them, at least half to some of the larger traumas, I shouldn't say most, many of them, at least half with some of the more significant traumas like Hurricane Katrina, will experience psychiatric symptomatology, even reaching the level of a diagnosable mental illness when you carefully look at it in the ensuing few months, as much as 6 months after the mass trauma event. So people will have a lot of symptoms. A lot of people will have a lot of symptoms in the context of a disaster, but only a minority, a significant minority, but only a minority of those will go on to have long-term or chronic experiences with mental illness as a consequence of involvement in those disasters. What puts people at higher risk? Few social supports, a history of trauma or mental illness previous to the disaster, people who were exposed most directly to morbidity or mortality, people who had, for whatever reason, a severe acute psychiatric reaction to the disaster, and people who are experiencing ongoing stressors. This is particularly relevant to the current context, including occupational and financial strain. There's no single variable that determines an individual outcome. Each of these and other variables raise risk for experiencing long-term or chronic experiences with mental illness that demand care. Social inequality, I want to emphasize this one in the context of the current pandemic. Social inequality and health disparities both predict and exacerbate vulnerability in marginalized populations. We have a pandemic that is dramatically influencing minority and underserved communities, health disparity populations, and mental health disparity populations to a much greater degree than the general population. And that means that those individuals from those communities are essentially doubly at risk. Number one, they're more likely to have been impacted. And number two, they have these existing risk factors that raise their risk of mental health consequence. Next slide. How do we move forward to promote recovery? Practical assistance, shelter, food, safety, economic stability. These are crucial parts of the mental health response. Practicing healthy coping strategies is something we've been advocating for at NIMH and really across the government for the entirety of the pandemic, and can really, really help. And Nora will comment on this more, but one factor is reducing or avoiding substance use. And then finally, treating new or worsening illness. Evidence-based screening, assessment, treatment, and care coordination may be expensive, but it is cost-effective ultimately, and it will help reduce the long-term mental health impacts. Next slide. How might we do that in the context of the current pandemic? Prior to the pandemic, telehealth had been expanding. The pandemic rapidly resulted in regulatory changes that allowed us to expand telemental health. And this has been, we hope, an important part of the response that hopefully reduces the long-term impacts. Next slide. I wanted to show you in particular one concern. Sorry, next slide, please. One concern of telemental health approaches is that they might not reach these disparity and vulnerable populations that we've been talking about. And although we don't have full answers on it, there is, at least in the context of this healthcare management network, the Mental Health Research Network, which of course includes a wide variety of individuals, but all have mental health care. There are Medicaid participants in this group, but here at least there is not evidence that telehealth results in worsening of disparities. So shown on here are three different graphs showing the in gray, in-person mental health visits in number, in orange, mental health video visits, and in blue, mental health telephone visits. And what you can see is that starting in March, that's 10 weeks after the beginning of the year, starting in March, there was a dramatic drop-off in in-person visits across this network, and but there was a subsequent increase in video visits and telephone visits in whites, in blacks, and in Hispanics within the context of these networks. So there is the potential for telehealth to fill in, and you can see only partially fill in, but fill in for mental health visits and increase access to care if it can be done properly. And we know from prior data that telemental health and video mental health can be as effective as in-person mental health for many, many conditions. Next slide. So what are the questions left to us in the context of this pandemic? We are a research organization, the NIMH, so we don't want to just disseminate knowledge. We want to expand knowledge. Next slide. We have put out a number of different funding opportunities. We've funded already many, many grants. We have a general COVID-19 notice of intent to notice of information for to fund work that's related to the mental health impacts of COVID. This includes many of the different approaches that we normally use across our portfolio, including simulation modeling and system science, including community and digital healthcare interventions. And it's that intervention piece that we're really, really big on. We know from prior work in epidemics and mostly mass disasters that there are effective evidence-based means of reducing the mental health impacts. And we want to conduct the research that shows how those can be implemented rapidly. And we've already funded many grants in this area, and we will continue to do so. Next slide. One of the ways that we've done this is paired with other NIH institutes, including the National Institute of Drug Abuse. We have a social, behavioral, and economic work group with 60 members that has funded 52 supplements to date. Over $25 million already went out the door in a matter of weeks after the pandemic started to study in particular the impacts and interventions that work in mental health disparity populations and other vulnerable populations, including older adults, frontline workers, children, racial and ethnic minorities, both rural and urban. And this is going to fund, or this is funding already, impactful research to reduce the mental health and social and behavioral impacts of the pandemic. Next slide. We've also promulgated a number of different resources to help, as I mentioned before, with coping mechanisms. Next slide. And with that, I'll return to our NIMH's overall vision and mission and just say that we are committed to doing what we can to understand and mitigate the impacts of the pandemic and promulgate the information that we know so that people can deliver evidence-based care in the setting of the pandemic. And with that, I'll hopefully reasonably on time, I'll turn it over to my colleague, Nora.
Thanks very much, Josh. It's a pleasure to be here in this meeting and to share the podium with my colleague, Dr. Josh Gordon, who you just scared. And too, I want to thank the National Academy for organizing this. What I'm going to try to do is give you a perspective of the challenges that we're facing as a country during the pandemic as it relates to the problem of the opioid crisis. And I'm going to try to address other areas that are also very much affected related to drug use, because currently we have, for the past 2 decades, trying to address the devastation the opioid crisis has given to our country. And then this is confounded with the pandemic. So can I have the next slide? In order to understand the nature of what is in front of us in this intersection of the opioid crisis and the pandemic, it is important to recognize that the opioid crisis has been one that has been changing very, very rapidly. It initially was triggered by the overprescription of opioid analgesics that then were diverted, or where people then improperly prescribed, became dependent on, and that resulted on the first wave of overdose deaths from prescription medication. Along the way, there started to be a significant rise in heroin that you see there in the gray color. That around 2011 actually started to significantly contribute to increases in overdose deaths, despite the fact that the prescription of opioids was starting to get stabilized and reduced. And that was the second phase. And then around 2013, 2014, we see an escalating steep curve that you see there in orange that is accounted by the overdose mortalities associated with fentanyl, which is a synthetic opioid of extremely high potency, at least 50 times higher than that of heroin, but also one that has very fast pharmacokinetics, which means it gets into the brain extremely rapidly, producing respiratory depression in many instances prior to the ability of anyone to provide with the resuscitating drug naloxone. And then to make things more complex, over the past 4 years, we have seen significant increases in mortality associated with psychostimulant drugs. And there in blue, you see cocaine, one of the psychostimulant drugs, and in yellow, you see the increases from methamphetamine. And currently, if you look at the numbers themselves, the majority of cases from there as of 2019 were due to fentanyl, and almost the same number now is accounted by the combination of cocaine and methamphetamine. In many instances, these actually deaths are actually ascribed to the multiple use of drugs, which reflects the market of drugs, which are frequently laced with fentanyl in order to increase their potency. And as of 2019, where we actually had thought that we have made some progress in reducing these overdoses by implementing specifically 2 major measures that we have in order to prevent them. Number one, expanding the access to medications for opioid use disorder, be it methadone, buprenorphine, or extended release naltrexone. And the other very effective strategy was expanding the availability of naloxone, which when properly administered, can reverse an overdose and save a person's life. Now, these strategies, which have proven and quite effective, fairly large effect sizes in preventing mortality, are much less effective when it comes to fentanyl and are not necessarily effective when it comes to psychostimulant drugs. And unfortunately, we do not have currently any FDA-approved drug for the treatment of psychostimulants, addiction, or for reversing that toxicity, highlighting the challenge where we are facing. So between 2018 and 2019, we had a 4.2% increase in mortality. And then 2020 came around, and then the pandemic hit the situation in ways that make it much worse. So can we have the next slide? One of the issues that has been extraordinarily frustrating is that when you are seeing these events happening, you want to understand how it's affecting the community. And the question that obviously has been paramount in our brains is how many overdose deaths are occurring currently with the pandemic. And this has been much harder to get in terms of in-time data that it has been. Fortunately, at least, we have that for the COVID new cases. That is not necessarily the case for overdoses. And so we rely on multiple sources, and this is data that relies on laboratories that do urine testing to quantify the number, the drugs that are available in individuals that are referred by the state or the prisons or the treatment programs. The data to the left is from Millennium Health, and the one to the right is from, I am actually blocking which of the laboratory it is, but one of the major laboratories. What you can see on the left is that there is a significant increase. And again, I want you to also note the data between March and May. We do not have data after May. And that's, again, highlights the difficulty of getting in real-time data sets. But what you can see is during that period of time, there's been a 32% increase in individuals that are testing positive for fentanyl, 20% those that are tested positive for methamphetamine, 10% for cocaine, and 12% for heroin. To the right, and the laboratory's Quest, you're actually seeing the data before COVID-19 and during COVID-19, also limited up to May. So we don't know what has happened in the past 6 months, but even without the restricted data set, you can see significant increases in the positivity rates of urines that are being sent to this laboratory. And it is occurring at all the ages, and it is occurring both in males and females. And the Quest laboratory also showed that a pretty dramatic increase in terms of drug combinations that were observed much more during COVID than before COVID. Now, this is drug use. And as Dr. Gordon mentioned, we know from other indicators that the consumption of drugs, new initiates or people that were already taking drugs has just gone up. But what about overdoses? Then let's look at the next slide. And this is where, again, we have to be very creative and try to get a sense of what's going on. And this is one of the measures that we have, which is the overdose detection mapping application that is funded by the HITA, an organization that monitors areas of high consumption of drugs. And what you see here is the reports of areas where the overdoses have increased significantly from in the first 5 months of 2020. And you can see a significant increase in overdoses in our country as of May, 42%. The next slide actually is the slide that relates to the data, the provisional data obtained from the CDC. And the CDC has actually accelerated enormously the capacity to provide with data in terms of overdoses. So as of now, we have data that goes up to April 2020. Some of it is provisional in that all of the states have not necessarily certified all of the death cases. And even though it may not be precisely accurate, it does give us an idea of what's happening in the country, at least until April of 2020. And if you look at the data overall, between April 2019 and April 2020, the CDC is reporting a 13.2% increase in overdose mortality. The prior slide was overdoses. It doesn't necessarily mean that those were overdose fatalities. The data that you see here and that 13.2% is overdose fatalities in our country. Now, this data shows the regional geographic variations that have been observed and persistent throughout all of the opioid crisis, with some areas actually experiencing, like Delaware and Wisconsin and Rhode Island, extremely high rates of increases in overdose mortality, and others lower rates. But overall, we can see that the COVID pandemic is exacerbating the risk for dying from overdoses. Next slide. The other issue that we need to keep in mind as we're addressing the intersection between these two very challenging situations that we're living is that of the risk of people that have substance use disorder of, on the one hand, getting infected, and if they get infected, having worse outcomes. And as Dr. Gordon mentioned, there appears to be not just an increase of getting infected for individuals with substance use disorder, use disorder as it is for individuals with mental illness, but it also, very unfortunately, is emerging too that they are at much higher risk of adverse outcomes. So to your left, you see the adjusted odds ratios based on analysis on electronic health records that represent close to 20% of the adult population in the United States, that show that regardless of the substance use disorder, AUD, alcohol, cocaine, cannabis use disorder, opioid use disorder, tobacco use disorder, all of these individuals are at an increased rate of becoming infected with COVID. And again, the reason for that increased risk of infection is likely to reflect both their social circumstances and living conditions, but also very importantly, the adverse effects on physiological effects of these drugs on systems that are actually direct targets of the COVID infections, such as is the case for pulmonary function, cardiac function, and immune function. Not surprisingly there, on the basis that these drugs are affecting pulmonary function, cardiac function, metabolic systems, and immune systems, when these people become infected with the virus, they're much more likely to end up hospitalized and they are much more likely to die. So to the right, you see actually the death rates among COVID patients with substance use disorders compared against those of the general population. And this data is data up to July. And as you know, the rate of death has decreased in our country when people get infected due to the better way of understanding better how to manage them. But in the slide, I'm also distinctly separating the deaths associated with African American and Caucasians that have led the country to realize the horrible disparities that exist between African Americans and Caucasians. And you can see significantly higher rates that we've all seen these among African Americans than Caucasians, that in part reflects the fact that actually individuals of African Americans, Black individuals, are much more likely to have chronic medical conditions that put them at risk for the adverse outcomes of COVID. And if you take that into account and you just actually understand that having a substance use disorder significantly increases your risk of dying. And what is chilling is that despite these very high rates of increase in death from substance use disorders, they are even higher for individuals that are African Americans. Again, highlighting further the concept of actually disparities and how ultimately multiple factors seem to be exacerbating the outcomes in individuals of underrepresented groups, even when the main factor that we were actually analyzing here was that of having a substance use disorder. I also want to comment that the highest risk occurs in individuals with opioid use disorder. And as of now, for example, we do not know the extent to which actually having being on an opioid itself is increasing your risk of dying because of its depression, respiratory depression, depressing effects. Next slide. So these are some of the multiple factors that are contributing to this higher risk in this population and the high mortality, including also the fact that individuals with substance use disorder are also much more likely to have chronic medical conditions, again, exacerbated in African Americans. And yes, Dr. Gordon spoke about the adverse effects of stress that have been linked, not just with increasing risk of mental illness and drug use, but on relapse of individuals that are on recovery. There is also the extraordinary important contribution, and I want to actually highlight it. So I put it in capital letters of stigma, because stigma has had devastating consequences in the opioid crisis and in the pandemic, and in their intersection, this basically has brought to our attention that this is something that we need to systematically abolish. Stigma makes people not want to seek treatment, and it exposes them to much higher risk behaviors. And ultimately that, of course, results in much worse outcomes. There are other issues that have contributed, which is among all the other aspects of it, as the increasing demand of care for individuals that are getting infected in healthcare system. This has jeopardized access of the healthcare system to treat individuals with an opioid use disorders. So there has been a limitations on the systems that we were using in the past to provide them with treatment. And also the support systems that allow them to actually be able to help them stop taking drugs and to stay on treatment have been, many of them closed by the pandemic and its consequences. And Dr. Gordon mentioned it straightforward. I mean, people that have mental illness, people that have a substance use disorder are much more likely to end up homeless and or are much more likely to end up incarcerated. And both of those environments significantly increase their risks. And ultimately, I think that another aspect that we need to consider is that the decimation in some places of the economy and the opportunity for jobs further increases the levels of stress and the ability of individuals to achieve recovery, since one of the main active ingredients is their ability to find a job and to feel that they are useful in a given society. Next slide. And this brings me to the last slide, because I think that as we look at all of these components, and Dr. Gordon mentioned this, is the social isolation, and never underestimate how powerful social systems are and how devastating social isolation can be for an individual. And in the case of drugs, we know now for more than 2 decades that if you put animals in environments that are complex versus putting them in isolation, the animals in complex environment with multiple behavioral choices do not take drugs. It is the animals that are in isolation in a cage that rapidly take different types of drugs. And so that's actually what we've done. We put animals in little cages. There's nothing else to do but a lever. And yes, they press the lever in order to get drugs. Now, this is a more recent study from 2018 from the lab of Javin Shaham, led by Beniro et al., in which they actually very cleverly gave an alternative to animals in these little cages. One lever for getting the drug, the other level for getting the opportunity for a social interaction with another animal. And you can see to the left, when it sort of says, when they have that choice, the animals choose social. They don't take heroin. They choose the social interaction. And I think that this is clearly telling us, if we give this animal a choice, the opportunity to have a social interaction, then heroin, no matter how rewarding it is not chosen over it. However, if we do penalize that social interaction, such that when the animal, for example, goes and presses for the lever to achieve the social reward, they receive a shock, and then they can have access to the animal, then the animal stops pressuring for that lever and instead starts pressing for the heroin level. And I bring this in terms of saying and bringing back the concept about how we can, basically this pandemic is making us even more aware why we need to address stigma, because stigma penalizes social interactions. And if we want people to actually be able to achieve recovery, if we want to be able to prevent drug use, then we need to ensure that we are able as a society to provide social interactions that are rewarding and they are meaningful. And it is through them that we will be able to actually also not just prevent young people from taking drugs, we will also be able to prevent the devastating consequences from addiction. And with that, I want to thank you for your attention. And I pass the microphone to the next speaker.
Yes, thank you very much. This is Lark Wong from SAMHSA, and I want to thank you, Dr. Gordon and Dr. Volko, for your very informative presentations. You've both cogently highlighted the interaction of the COVID pandemic and mental health and substance use disorders in the general population, and provided a very clear picture of alarming increases in these symptoms and disorders, the increased burden on the treatment systems, as well as new policies, new opportunities related to treatment, telehealth, and reimbursement. Our next speakers will address the interplay of the pandemic and mental health and substance use issues and the disproportionate impact, particularly on communities of color, which Dr. Gordon and Dr. Volko have also acknowledged. The confluence of the COVID pandemic, the associated economic crises, widespread racial violence and unrest has placed enormous hardships and stress on these communities. Our next speakers will highlight these issues and some strategies to address these particular stressors in these often underserved and marginalized communities. Our first speaker is Dr. Michelle Williams, who is the Dean of the Faculty of Harvard Chan School of Public Health. And she has a joint appointment at the Harvard Chan School and the Harvard Kennedy School.
She's an internationally renowned epidemiologist and public health scientist. More on her bio can be found with the materials for this session. Our second speaker following Dr. Williams will be Dr. Brian Smedley, who is Chief of Psychology in the Public Interest, where he leads the American Psychological Association's efforts to apply the science and practice of psychology to fundamental problems of human welfare and social justice. And he is also a national thought leader in the field of health equity. Again, his extensive bio is included with the materials for this webinar. I want to remind participants to please put questions in the question and answer section, and as we will have discussion following these two presentations. So I'd like to turn it over now to Dr. Williams.
Thank you. Good afternoon. It's a pleasure to be here, and I look forward to our question and answer session. What I'd like to do in my session is to essentially look at COVID through the prism of what has really emerged as three converging convulsions. Maureen Dowd several months ago said that we were experiencing three convulsions: a biological convulsion brought on by the pandemic, an economic convulsion that the pandemic has uncovered, and a societal convulsion, which really came to fore as a traumatic event that we all saw as George Floyd's life was taken away in the 8 minutes and 46 seconds that we observed. And so this three convulsions really brought to the fore a series of conversations and a realization of just how important and fundamental racism is as a public health crisis. And so I will try to, in my time here, discuss the impact that COVID-19 has had in communities of colors through the lens of racism as a public health crisis. I begin with a quote from Dr. Martin Luther King Jr. in 1966, when he addressed the Medical Committee for Human Rights. And in that address, he said, "Of all the forms of inequality, injustice in health is the most shocking and the most inhumane because it often results in physical death." The unequal health outcomes that you've heard from both Dr. Gordon and Dr. Volkow, and which is referred 50 years ago by Dr. King, speaks to a stark disparity that exists over 50 years ago and is even more clear today. We don't have to look any further than the pandemic of 101 years ago, the influenza pandemic, to recognize just how true and how persistent health disparities has been. Next slide, please. Just over a century ago in the 1918 influenza, while this was ravishing populations in the United States, at the height of the Jim Crow era, I might add, Black people who came down with influenza were largely left to fend for themselves. They were stigmatized for getting sick, even blamed for inciting the outbreaks. And when they did go and seek and receive medical help, they were relegated to substandard hospitals where the healthcare and social systems that were available to them would become quickly overwhelmed. If that sounds heartbreakingly familiar, it should. Next slide, please. Some in the media and in the research community have called COVID-19 pandemic a great equalizer, since all of us in every corner of the country continue to be at risk. This virus does not discriminate, but our society always has. And because of this persistent discrimination, week after week, month after month, communities of color have borne the brunt of this crisis. The really unfortunate truth is that no matter where you live in the United States, your experience with COVID-19 has a great deal more to do with who you are. And that is a reflection of the systemic inequality that has plagued our country and has left community of color behind since long before this particular COVID-19 pandemic began. And the crisis really is undergirded by an inequality in exposure to the disease, but it is also an inequality in the healthcare access for those who get sick. And it is also undergirded by an inequality in the underlying health conditions, the pre-existing conditions that COVID-19 makes all the more deadly. Essentially, what this pandemic has done is shine a harsh light on what public health experts have long grappled with, and that is racism is a public health crisis. And this crisis is manifest in the scourge of police violence that disproportionately kills Black Americans, also in the many vestiges of colonization, of slavery, and discrimination, as well as in a pandemic that is devastating the population of color. It is also manifest itself in the disproportionate mental health impacts that you've heard in the previous two talks. These are disproportional mental health impacts that is current and is unfolding in Black communities. Next slide, please. A recent study by the Centers for Disease Control and Prevention found that more than 18% of Hispanics and 15% of Black respondents reported having suicidal thoughts, suicidal ideation, compared to their white counterparts of 8% or Asian Americans of 7%. In the same study, Black and Hispanics also reported a higher rate of depression, stress-related disorders, and substance use to cope with the stress brought on by the pandemic. We also now have data that COVID-19 patients are more vulnerable to mental health issues, with 1 in 5 recovering COVID-19 patients developing some form of mental illness within 90 days. Add into that the fact that African Americans are also being disproportionately impacted economically by this crisis, as well as experiencing the trauma around the killings of George Floyd, Breonna Taylor, Jacob Blake, and others. And we are essentially staring down at what is a true mental health crisis, as well as the biological crisis of this novel virus. But the truth is, systemic racism has been impacting the physical and mental health well-being of Black and Brown Americans long before COVID-19 came along. First, there was the toll of individual racism that people of color experience every day, like being followed around in stores or having their health concerns downplayed by white health caregivers. It is well documented that relentless assaults of daily discrimination leads to a wear and tear on both the body and the mind, which in turn can cause a range of adverse health outcomes, from high blood pressure to chronic heart disease, to immunodeficiency, and even to accelerated biological aging. The high burden of these non-communicable chronic disease in Black communities can be traced back to centuries of racial oppression in policy choices, from segregation to the gutting of school and social programs, to mass incarceration and voter suppression, even tracing back to racist housing policies such as redlining. Next slide, please. I'd like to take a little bit of time and delve a little bit more deeply into the example of redlining. And this animation on the slide that you're seeing is from a New York Times infographics, an article that really delved into the legacy of redlining. In the 1930s, the federal government created maps of hundreds of cities, labeling Black and immigrant neighborhoods as hazardous. For decades, residents in these so-called hazardous neighborhoods were denied home loans and credit, and were financially left for dead, essentially. Property values as a consequence deteriorated, and austere housing projects were built in these communities. And while wealthy white neighborhoods were dotted by fresh produce vendors, quality schools, and open green spaces, the red line communities became sites for federal highways, became polluting grounds, and became essentially concrete jungles. The mental health impact of this legacy of redlining were profound. Those of us in public health have long known that poverty is one of the major risk factors for poor mental and behavioral health. Housing instability, in particular, can provoke and even exacerbate anxiety and depression and substance use. Those living in segregated neighborhoods also experience a great sense of social isolation and exclusion. Fast forward to today, and this form of structural racism, this policy of redlining, is still playing out in very real ways. In a recent study found that neighborhoods that were redlined back in the 30s see more extreme heat, for example, than those that were not redlined. Atlanta is one such example. In an Atlanta neighborhood that was rated as best in the 1950s, are 5.1 degrees cooler than the city average. And this is due, in fact, to the parks and the trees that exist in these neighborhoods that lowers the air temperature. Meanwhile, neighborhoods that were labeled as hazardous, Black and brown neighborhoods, are 3.6 degrees hotter due to asphalt and highways that radiate the heat. That difference of more than 8 degrees, seemingly trivial 8 degrees, impact biological systems that impact population health. And to come back to mental health again, according to a report released last year by the Congressional Black Caucus, suicide attempts for Black adolescents rose 73% between 1991 and 2017. In fact, suicide is now the second leading cause of death among Black children between the ages of 10 and 19 years. Access to healthcare also continues to be a significant challenge for many Black Americans. According to a 2018 survey from SAMHSA, of the 4.8 million Black Americans with mental illness, nearly 70% do not receive treatment. That's 70% of the population with mental illness not receiving treatment. Finding a mental health provider who shares the same cultural background is a barrier for obtaining health in Black communities. According to the American Psychological Association, only 4% of psychologists in the country are Black. In other words, the connection between physical health and mental health, and physical and mental health disparities, and the wider set of the racist forces is undeniable. And COVID has made this ever more clear. But it does not have to be this way. Today, more than ever, we have the data to illuminate the many ways in which structural racism drives inequality, both within the healthcare system and through the disparities in wealth and opportunity and access to quality education, housing, healthy foods, and green space. Our challenge in public health then becomes one of awareness and funding. As things stand right now, public health programs in this country have to scrape by on a shoestring. We're so often in public health the first on the chopping block in an economic downturn. Think about this. The United States spends more money per capita on healthcare than any other country on earth, but just a mere 2.5% of our health expenditures go to public health programs. As a nation, we spend at least $4.5 billion less on public health than is needed to provide adequate level of protection, prevention, and care. All of this has to serve as a wake-up call, not just to the injustices born of COVID-19, but to the inequities that may not make headlines, but nonetheless drive the health, mental and physical health disparities that we have all been discussing. How do we bend the arc towards better population health equity? I think to do that, we have to demand radical, large-scale investments in public health. These have to be investments at a municipal, state, and national level. We need to make a national 21st century mental and physical health disease surveillance and reporting system that makes the data much more timely available and much more integral to have information about the social determinants of health, those drivers that drive 80 to 90% of the health and wellness of populations. We also need to invest in building a more diverse pipeline, a pipeline with a diverse talent and a robust mentorship system at the state and local public health departments across the country, so that they are better able to provide culturally competent, trusted services to communities at risk. We also have to invest in place-based interventions that not only address physical and mental health care, but also the many social determinants of health, like improving school quality, improving employment opportunities, expanding access to green space and healthy food, and championing effective community policing to us and access to preventative care of the highest quality. All of these things can help to create healthier, more thriving communities where all people can live. In the last few seconds, I want to share a quote from the writer Ta-Nehisi Coates. Ta-Nehisi eloquently stated the following: "An America that asks what it owes its most vulnerable citizens is improved and humane. An America that looks away is ignoring not just the sins of the past, but the sins of the present, and certainly the sins of the future." We must be an America that finally reckons with the sins of discrimination that pervades American society in healthcare and across all facets of our daily life. If we're able to do that, in the end, that will be the great equalizer, and it will save countless of lives and ensure an opportunity for all to thrive. The final slide, please. With that, I want to thank you for your attention, and I look forward to an active Q&A. And now I will turn the podium over to Dr. Smedley.
Thank you so much, Dean Williams. First, I want to thank the forum for organizing this very important discussion. APA is a very proud sponsor of the forum, and we could not be having a more important or timely conversation. To begin, I want to just closely associate myself with Dean Williams's remarks. Dean Williams hit the nail right on the head. If you want to understand inequity and health inequity in this country, you have to understand our history, and you have to understand how racism operates at multiple levels. For too long in this country, we have pretended that racism is simply an interpersonal phenomenon. A few bad apples, perhaps wearing sheets over their heads, harboring animus and bias towards others. Well, certainly that persists, as we've seen. But we need to understand that racism is more than an interpersonal phenomenon. Racism operates at structural, institutional, interpersonal, and internalized levels, all of which are complicit in the deep inequities that we're seeing as a result of the COVID pandemic. Dean Williams pointed to one of the most pernicious and foundational forms of racism that many scholars believe is complicit in not only the health inequities that we see today, but also the educational, occupational, and wealth inequities, and that is residential segregation. Segregation itself was not an accident. It was a deliberate policy practice, a law in this country for most of our history. That practice was made unlawful in 1964 as a result of the Civil Rights Act and the 68 Fair Housing Act. But of course, segregation persists. And this is because of a number of factors, including the persistence of interpersonal forms of racism in the real estate and housing industry. But what Dean Williams pointed to in terms of not only the segregation of people of color, the separation of people and sorting based on race, but the deliberate disinvestment in communities of color is exactly why we see the inequities in health, wealth, education, occupational status, et cetera, that we see today. So we need to understand that history, deeply foundational to understanding what we're experiencing now in the current COVID-19 pandemic. So I thank you, Dean Williams, for lifting up those processes which are so essential to understanding racism in America and how it works. I would go further to say that the fact that we have not corrected that historical inequity is in itself a form of racism that maintains the deep racial inequities that we're seeing today. Next slide, please. I want to touch on what we at the American Psychological Association are calling the dual pandemics of racism and COVID-19. The COVID-19 pandemic, of course, is very, very recent in our history. The racism pandemic, of course, is at least 400 years old. So what we're seeing is that a large share of Americans are experiencing symptoms of distress, but people of color are experiencing heightened distress during this period of racial unrest and pandemic spread. So what we're now witnessing is in fact a syndemic in which the COVID-19 pandemic is fueled by and is exacerbating pre-existing social and economic inequality. And while it's true that people of color, particularly African Americans and the Latinx population, Native Americans, Pacific Islanders, and many others are at increased risk for poor outcomes should they contract the COVID-19 infection, we must be clear that those pre-existing conditions in themselves were created by the racist policies and practices of this country, including practices such as residential segregation and redlining. That's one fact that I think has not been apparent to most Americans in the media coverage about pre-existing chronic conditions and the heightened risk for poor outcomes among people of color. Those pre-existing chronic conditions did not just miraculously appear. They're not the result of biologic, genetic, or behavioral factors, not the result of a lack of access to healthcare alone. They were in fact created by policy and practice in this country that deliberately and significantly disenfranchised and marginalized many populations, particularly people of color. Next slide, please. The American Psychological Association's Stress in America survey has been an annual survey for several years, and so we are able to look back over time at our data. The most recent APA Stress in America survey was fielded this past fall, and what we found was quite striking. 2 in 3 Black adults cite discrimination as a significant source of stress in their lives. This was an increase this fall over the 55% of Black Americans who reported this in May to June. About 45% of all US adults say that being their race is difficult in today's society. About 40% say that their gender is difficult in today's society. But more than 3 out of 4 Black Americans report that their race is difficult in today's society. About 60% of US adults say that police violence toward people of color is a significant source of stress in their lives. About 36% said the same when APA first started tracking this data point in our 2016 survey. So a significant increase for the entire US adult population. And of course, Black adults are most likely to report this. Nearly 70%, nearly 80% reporting that police violence toward people of color is a significant source of stress, compared to about 72% for the Latinx population, 61% for the Asian American population. Next slide, please. Of course, COVID-19 has merely exposed the inequities that have been persistent in our nation for generations. And we're seeing inequities across many identity lines, not just race, ethnicity. We're seeing that older adults, particularly those in marginalized groups, older adults of color, are most likely to lack the resources during the crisis that you would need to help mitigate risk and to manage against infection, such as healthcare and community services. Aging services are also saddled by the same racial inequality that marks America's COVID-19 crisis, as this sector disproportionately employs and serves people of color. Direct care workers, for instance, are predominantly people of color, placing them on the front lines of the pandemic. And these low-wage workers, who are primarily women, people of color, and immigrants, often lack paid leave and do not earn enough to weather even a modest disruption in pay. Next slide, please. We know that people with disabilities may not be able to physically distance themselves from others or to take other protective measures. Similarly, people with low incomes may not be able to physically isolate, increasing risk compounded by challenges such as a lack of access to safe, stable housing, access to healthy food, or the resources to withstand economic downturns. It's also true that immigrants are facing unique challenges that may increase their risks and chances of poor outcomes if infected. It's important that we recognize that even legal immigrants may fear accessing public health or social services in light of the new public charge rule, which suggests that those that seek such services may have challenges to obtaining green cards or even citizenship status down the line. And those without documentation may fear detention or deportation. And of course, as has been noted, institutionalized populations, including those who are incarcerated, migrant families in detention centers, face heightened risk for infection due to the circumstances of their institutionalization. Next slide, please. Here are some more data from the APA Stress in America survey. This is the percentage of US adults reporting that fear of contracting the virus is a significant source of stress. Here we see that the Latinx population is the population showing the highest percentage of those reporting fear of contracting the virus, with nearly 80% reporting that this is a significant source of stress. African Americans, Asian Americans are also reporting that fear of contracting the virus is a significant source of stress in their daily lives. Next slide, please. Also from our Stress in America survey, the percentage of US adults reporting that meeting basic needs such as food and housing is a significant source of stress. Again, the Latinx population leads all racial and ethnic groups in our sample, with nearly 70% reporting that meeting basic needs is a significant source of stress, followed by the Native American population at nearly 60%. I need to point out, however, that the sample sizes for our Native American population were relatively small, which leads to a relatively large confidence interval for this population. Next slide, please. And again, from our Stress in America survey, these are the percentage of US adults reporting that accessing healthcare is a significant source of stress. Again, the Latinx population, with nearly 70% reporting that accessing healthcare is a significant source of stress, leads our population, followed by African Americans, Asian Americans, and again, our Native American sample is small, but in many cases, these populations are experiencing significant stress in attempting to access healthcare as well. Next slide, please. These are some SAMHSA data. Dean Williams alluded to some of these data earlier, but I just wanted to unpack these data a little bit further. So I'm grateful to our colleagues at SAMHSA for these data. Now, these are from 2018, so this predates COVID, but you can only imagine, given the heightened risks that COVID is imposing for mental health and substance use disorders, that these data are perhaps underestimates today. So looking at the bar on the far left, we see that SAMHSA estimates that about 2.3 million African Americans need treatment for substance use disorders, but about 90% are not receiving treatment. 4.8 million African Americans need treatment for any mental illness, but about 70% are not receiving treatment compared to the overall US population receiving treatment at about 56.7%. About 1.1 million African Americans have a serious mental illness, and only 42% of those are not receiving treatment compared to the overall US population not receiving treatment for serious mental illness at about 36%. About 1.1 million African Americans have a co-occurring mental illness or substance use disorder. About 91% are not receiving treatment. And then among teenagers, when we look at major depressive episodes, about 330,000 African American teens have experienced a major depressive episode, but about 2/3 are not receiving treatment compared to the overall US population not receiving treatment at 58%. Next slide, please. Among the Latinx population, we see similar discouraging numbers. Among those who have a substance use disorder, about 3.3 million in the Latinx population have a substance use disorder. About 90% are not receiving treatment. Nearly 7 million have any form of mental illness, but about 2/3 are not receiving treatment. 1.5 million in the Latinx population have a serious mental illness. 44% are not receiving treatment. 1.3 million in the Latinx population have a co-occurring mental illness and substance use disorder. About 93% are not receiving treatment. And among teenagers with a major depressive episode, SAMHSA estimates that nearly 900,000 Latinx teens have experienced a major depressive episode. 62% are not receiving treatment. So clearly, we are still seeing barriers, be they related to culture, language, finances, or simply having services available in one's community, or the availability of culturally appropriate services. Next slide, please. So there are a number of policy strategies that are needed to combat COVID's disproportionate impacts. And again, I thank our colleagues at SAMHSA for identifying these factors. Data disaggregation remains a key factor and remains an unmet need. We need comprehensive and complete data related to COVID-19, including testing, hospitalizations, admissions, fatalities, disaggregated by race and ethnicity at local and national levels. And I would add that we should probably include other demographic factors as necessary, such as ability status, language status, et cetera. Notably, a number of states have reported data on race and ethnicity that are incomplete. This is simply unacceptable. We still have high rates of incomplete data, and with appropriate training of both frontline administrative staff as well as patients, we can improve our completeness of our data with respect to race and ethnicity. We need flexibility in treatment policies and payments. SAMHSA recently released a guide for opioid treatment programs, providing flexibility with things like take-home methadone treatments during the pandemic. We need our navigators and community-based providers to be able to take advantage of federal stimulus opportunities. The CARES Act, for example, provided economic stimulus for small businesses, and we need our frontline community-based providers providing behavioral and mental health services to be able to take advantage of these services so that they can keep their doors open. And we have, of course, expanded flexible coverage for telehealth. And I appreciate the fact that this was highlighted by other speakers. Certainly more research is needed on telehealth. But when it comes to telehealth as an equity concern, I strongly suspect that telehealth has great potential to break down some of the cultural and linguistic barriers that many in communities of color face. So for example, if you live in a community where you cannot find a provider, a psychologist or other behavioral or mental health provider who provides services in your language or other culturally appropriate services, you do not have to drive a long distance under this new rule. You can find providers in other communities, typically in your state, but you can find providers in your community who can provide language and culturally appropriate services. So more research is needed here, but I think there is great potential for telehealth, even with barriers to access to technology to improve access to care for many in communities of color. Next slide, please. SAMHSA has also identified community-based strategies to combat COVID's disproportionate impact, taking advantage of the trusted and respected positions that faith leaders hold in many communities of country. In many communities of color. They are providing support, information, and spiritual leadership in many communities of color. They are trusted messengers and influencers who have a long history of addressing health and mental health issues. And so they can provide a great service, particularly as we're thinking about the need to get vaccines in every community, and particularly those that are hardest hit. Our faith leaders and our community-based organizations can do a great deal to improve trust and increase vaccine acceptance and take-up rates. Community-based organizations, again, have strong track records and often provide multiple services that are needed to integrate health, mental health, behavioral health, and social services. And community-accepted first responders are critically important. We need to understand who are the family members, pastors, neighbors, other community leaders who are trusted and influential and who can pass along needed, accurate information to members of these communities. Next slide, please. It's also true, as other speakers have noted, that our healthcare workforce absolutely needs to be strengthened. We need more and diverse and well-trained workers in health and mental health and behavioral health fields. But here again, virtual and telehealth opportunities can help. We know that there are instances where outpatient clinics, CBOs, and urgent care centers have ramped up the use of telephone and video visits. We can also augment our healthcare workforce with people who understand cultural differences in how patients interact with providers in our healthcare systems. For example, we can fast track immigrant, refugee, and bilingual healthcare professionals who have been closed out of US healthcare professions, who could increase the pool of culturally appropriate providers by over 200,000. According to SAMHSA. And then, of course, we know that community health workers or promotoras have been tremendously important in ensuring that we have members of our communities providing outreach, navigation services, coaching to those in marginalized communities who need this. These peers know the community, are familiar with the resources in the community, and are able to communicate effectively with their clients, and thus are critically needed during the pandemic. Next slide, please. I'll just close with a bit about an APA initiative called #Equity Flattens the Curve. Based on everything that I've discussed here, we launched this initiative specifically because we know that the health risks, burdens, experiences, and outcomes are not the same for everyone. We know that those communities that have been historically marginalized and disenfranchised, such as communities of color, are being hardest hit. Again, this is no surprise if you understand our history and some of the dynamics that Dean Williams was talking about. And so clearly, to flatten the curve, we have to tackle the bias, stigma, and discrimination at the root of these inequities and the structural forms of racism that are currently hampering our ability to provide equitable opportunities for good health for all. Next slide, please. We have 4 goals associated with #Equity Flattens the Curve. The first is to connect the diverse voices of health equity, public health, mental health, behavioral health professionals, and to educate policymakers and leaders regarding equity enhancing practices and policies. So again, as I noted at the outset of my presentation, people of color are at higher risk for infection and for poor outcomes as a result of the pandemic. But we also know that older adults, people with disabilities, in some cases LGBTQ populations, and many others are at heightened risk because of the persistence of bias, stigma, and discrimination against these populations. So we need to connect our voices together and create more powerful coalitions to ensure that our demands are heard. And of course, we need to reduce the bias, stigma, and discrimination at the root of these inequities, such as bias in access to testing. We know that in some instances, testing facilities and access to testing services is concentrated in already advantaged communities and is much harder to find in marginalized communities and communities of color. We need to ensure that these vital resources are available equitably and according to need. Third, we need to promote social cohesion, inclusion, and equity as necessary to help mitigate the virus's spread. We know from a large body of public health research as it relates to other chronic health and infectious conditions, that those communities that are characterized by high levels of social cohesion will fare better than those characterized by disruption, discord, and division. I firmly believe that this is one of the reasons why the United States is experiencing such challenges related to high infection rates and high mortality rates relative to other developed nations. I believe it is because we are a deeply divided country, and one that has been even more divided as a result of the resurgent racism and expressions of hatred leveled against many communities that we're seeing in recent years, and frankly, that reflect fears of a changing America, a changing demographic in this country. And finally, we need to promote policies and practices that reduce inequity and address the public health needs of diverse populations, such as improving our data collection systems to understand where and when the virus is spreading, and specifically with regard to the completeness of demographic data, and expanding federal and state safety net programs to ensure that those who are at greatest risk are finding that their needs are being met with respect to housing security, food security, having unemployment insurance so that they can weather through the pandemic. And as we see case rates and infection rates rising, it becomes even more important that we extend that social safety net to ensure that no community is left behind. Next slide, please. I'll conclude here. I thank you for your attention. I look forward to a very rich discussion. Thank you so much.
So I'd like to begin by thanking for fantastic presentations. Thank you to all of our speakers. And I'm going to invite our speakers to turn their cameras back on so we can have a panel discussion based on audience Q&A. We've gotten a bunch of great questions coming in through the Q&A function. So please join, yes, Dr. Volko, Dr. Gordon and Dr. Williams joined Dr. Smedley. This has been an impressive effort, I think, I want to just highlight to begin with, by our public health agencies and our research networks to pull together data to allow us to move quickly to understand the contours of these overlapping public health crises quickly that are the subject of our conversation today. So let me, without further ado, jump right into our audience questions. So the first relates to how the loneliness factor factors into dramatic increases in mental health and substance use disorders in the context of the COVID-19 pandemic, both generally and within communities of color. So if we could speak to the role of increased loneliness in the context of COVID and social isolation. I'll let any of our panelists begin. Dr. Gordon.
You're muted. I'm happy to go ahead and start, and I know Nora was trying to say something as well. I think certainly social supports are an important factor that we've learned from prior mass disasters and epidemics that play a role in mitigating the mental health consequences of these events. What we do not know is what the role that social distancing paradigms and other pandemic mitigation measures are playing currently in the level of symptoms that we're seeing, and or in exacerbating them, or perhaps making it more likely that they will result in more severe, longer lasting effects. We just don't know the answer to that. We do know that a lot of communities have rallied around other measures to ensure continued social connectedness. But I do worry, in particular, I worry in terms of vulnerable populations. I worry about single parents. I worry about elderly individuals living alone, and others who might be disconnected from support systems more severely by the physical disconnectedness. In terms of disadvantaged populations, communities of color, I worry about those without as much access to wideband and other technology-mediated social connectors. So those are things that we're worried about. I don't know that we have existing data on. Nora, I know you also wanted to say something.
Yeah, no, thanks, Josh. And certainly this is a major worry because we know that one of the most powerful reinforcers and a factor that is indispensable for our well-being as humans is that social interactions and connectedness. And this actually is relevant to all of our life span. And it's particularly though prominent and crucial during childhood and adolescence. And among the many things that we're worried about is how this isolation may be negatively influencing the development of children and their well-being. And we learn from observing others. It's crucial for us as social creatures. And as we go more into the virtual world, we are removing that opportunity for interactions in children or adolescents at a period that is crucial for them. So we are prioritizing right now, and again, by supplementing large programs that we had that were initiated before COVID in children and adolescents to understand how that lack of face-to-face contacts will be influencing the brain and how that may place these children and adolescents at greater risk of mental illness and substance use disorder. So this is one of our top priorities, while recognizing that the social isolation is a factor that is leading people to significantly increase the consumption of drugs and that it is extraordinarily stressful. So the challenge is what are interventions that we can do to mitigate as much as possible these adverse effects.
Do any of the other speakers want to chime in on this loneliness question? If not, I want to pick up on Dr. Volko, your reference to the schools and kids in schools, because this also has come up in the chat, and maybe some of our other presenters want to comment on it too. The specific question related to, and I know we're mostly focused on adults here, but how do you balance the mental health risks of not being in school for kids due to with the risks of COVID-19 physical health risks?
And I think that Dr. Gordon sort of actually clearly brought that up as an issue that we need to be concerned about. And also I think in linking it with a question before, how does these, the effects are going to be likely to be much greater for individuals that come from underrepresented groups or that in children that live in poverty, because their parents may not even be there to actually observe how they are doing in school because they have to work 2 or 3 shifts on a given day. And many of them actually don't have access to even the bandwidth that's necessary to be able to benefit from the classes. So we are very likely expanding the gap between those that have more access, more resources, and those that do not. And I think that that's an aspect that is extraordinarily worrisome because education is high quality education is one of the most consequential interventions that we can do to equalize outcomes as these children grow up into adults.
I would agree with that, and I would just add the question of the balance between children being in school, which clearly has very, very clear benefits, both in terms of kids' educational attainment and mental health, with risks. There are other risks that we need to consider for children of color. Children of color are increasingly concentrated in high poverty schools relative to the late 1960s. We are seeing a deepening of school segregation. Why do I raise that? Because in many cases, those high poverty schools have a crumbling physical infrastructure with respect to the school buildings themselves, with, in many cases, poor ventilation, other risks such as mold. So these are factors that can clearly exacerbate the spread of the virus, particularly if some of these facilities have poor ventilation and are otherwise less well equipped to ensure that our children are safe.
In addition to that, I'd like to add the concern about the widening not only of the race and ethnicity gap to opportunity through education, but the gender gap. You know, as Dr. Gordon alluded to, the single parent households are going to be particularly hard hit, are being hard hit. And young girls are really in single parent households called on as the care providers for their siblings. And we already know that even in the best of circumstances with availability to access to broadband, children in Black and brown communities in single parent households are going to be more likely to be called on to be care providers and less likely to engage in the educational process. So we really are looking at a collision of crises here that can really impact a generation of young people.
Dean Williams, I'm glad you brought, you added a little bit more complexity to the picture here. One of the more surprising pieces of data regarding the effect of inequality in minority communities is coming out of New York City, where in-person participation in the schools has been optional this entire school year. And by and large, minority communities are opting out at much higher rates. They're opting out of in-person schooling at much higher rates. It's a phenomenon we don't fully understand, but I have to imagine that part of the reason is that the minority parents are needing some of the older kids, at least, to stay home to care for the younger children. And I'm sure that there are many other complex reasons behind this phenomenon that we don't understand, but these issues are never single-faceted. As I mentioned in my presentation, you know, from the mental health perspective, there are numerous impacts that all raise risk, and from various societal perspectives, these are never single-issue areas.
One other question that came out in the chat related to this is this quite high increase in psychological distress among young adults. So the 18 to 24-year-olds, the 18 to 29-year-olds. Do we have any information at this point, or are any of our speakers willing to speculate on what's driving those extremely high rates?
I can speculate, because as I think that unfortunately we don't have sufficient evidence to say this is factual. But we certainly, from what we're observing, if you look at it in terms of 18 to 24 years of age, that is the period of time when the young adults are transitioning from being dependent on their families to going out into the community and being independent. And with a downturn of the economy, they are facing a world where it's much harder to get a job. And many of them, in terms of what their plans were in order to accomplish their studies or do whatever other goals they have, are basically put on hold at a period that is extremely important in determining what ultimately is going to happen to you. So this actually is one of the reasons why they seem to be so vulnerable. And it's also the age at which we're seeing the greater rates of substance use increases, and Josh was mentioning it also, but it's 18 to 24 where we're seeing also the highest rates of suicidal thinking based on the SAMHSA survey.
Yeah, I mean, I would echo Nora's. I think at this point, I'm not aware of real good data that parses it out. But I've got two anecdotes in my own family. My son graduated college. My daughter graduated high school. My daughter's in an unplanned gap year. My son is managing to keep himself busy, but he's certainly not on the career track that he hoped to be on. You throw in then as well the degree to which younger people of this generation are much more engaged around the issues of racial strife in this country, are much more engaged around issues of inequality, are much more engaged around issues of climate change. And this year has been one full of hopelessness, if we can imagine, amongst this younger generation. So those are all, as I said, speculation and anecdote, but it's not necessarily surprising we would see these high rates. Again, Now, one thing to put in perspective, though, is the rates, while frightening, we're talking about 40% of young adults having, some form of suicidal ideation, depending upon the survey, I should say up to that. Those rates are only about double the baseline, right? So it's consistent with overall a doubling in the level of mental distress in the United States. Now, a doubling is huge. It is very, very concerning. It is going to drive demand probably beyond capacity, but it is part and parcel with what we might expect given the severity of the current pandemic. And the good news behind it is if we can mount an appropriate mitigation response, we may expect, again, that a small minority of those individuals will go on to have significant sequelae, whether it be a suicide attempt or a long-lasting chronic mental illness. So we have an opportunity to respond. We have some tools to respond. I can't honestly say that we have a full-blown national response that is scaled to meet the demand, but that's what we're facing right now.
So one additional data question here from the Q&A, and that is connected to the impact of the pandemic on those with dual diagnoses, both generally and then again within communities of color, and what we know about adverse outcomes.
Well, we know, again, the data that probably some of the best data that we have is for analysis of electronic records and prescription indicators. And what we do know is if you have an individual that have an opioid use disorder, and I'm going to just focus on opioid use disorder because that's where we have the best data. And those individuals very, very frequently have comorbid depression. And the data shows that if you treat them with a medication for opioid use disorder, concomitantly with an antidepressant, you significantly reduce their risk of overdosing and dying when compared with those that may receive the medication without the antidepressants. And I think it clearly highlights that we need to create medical systems and train those that are providing the care of the importance on how to properly manage these comorbid conditions because they are more frequent than rare. And as you are looking at the COVID pandemic, which has increased the despair in the population, this is going to take an increasingly more important challenge to ensure that we are actually keeping individuals in treatment, and in so doing, we prevent them from overdosing.
Just add to that, another part of our challenge, as everyone on this call knows, is that people of color, in many cases with a substance use or mental health disorder, are more likely to end up incarcerated or in some other institutional setting where treatment is rarely offered and can be inconsistent in terms of quality if offered at all. So that challenges both our ability to fully understand the scope of the problem, but then of course the fact that we have criminalized this public health problem in itself is a huge policy problem that we absolutely need to reverse.
And I completely agree, and I'm glad you're bringing up the issue of incarceration, because I think that to start with, this is an issue that we need as a country to address. And as the presentations clearly showed, by not doing anything in a way that we're contributing, and we are becoming active participants in the practices that are very, very, very painful to recognize that we had as a country. So getting rid of the criminalization of African Americans or other minority groups because of usually, the reason why you have the overrepresentations, our substance use disorder, is fundamental. But also, I think also in terms of looking at what are solutions, is clearly there have been changes that have gone in the right direction, including, as mentioned too by Josh's presentation, the basically easier reimbursement for telehealth interventions. And what has been also very rewarding is to see that the justice settings, which in the past did not allow really very much for telehealth, now very rapidly have embraced it. And now this is accessible to individuals in jails or prison, which of course makes it much more likely that they will receive the treatment that they need, because then you don't need to have a physician in place in order to prescribe them antidepressants or prescribing medications for their substance use disorder. So access to telehealth has opened up the door to certainly improve the conditions that which individuals that are incarcerated are treated if they do suffer from a mental illness and or substance use disorder.
Dr. Williams, there are two questions here in the Q&A that are directed toward you, and I'm going to put them together. One relates to your comment about parks and trees and lowering air temperature. Can urban design play a role in bringing an equity lens to improving mental health in Black communities? That's the first one. And the second, connected to that, what are other examples of public health interventions that can improve mental health in communities of color?
Yeah, no, thank you for that. Place-based interventions, which I alluded to in my remarks, are really important here because many of the urban communities that are very hyper-segregated really require a massive amount of investment. You know, as we talk about solutions to support and enable Black and Brown communities coming out of this crisis, we have to really think about housing. In a matter of days, if not weeks, there's going to be a national crisis as the housing insecurity becomes not an if, but a when. And what we really have to do in terms of thinking about a way to address at the root the drivers that are pushing Black and Brown communities towards mental illness, towards substance abuse, is the conditions in which they're living. And so we really do have to think hard about the immediate crisis that's facing us right now, which is the eviction threat. And then we have to really think about place-based interventions that look seriously at urban design. You know, we still have large populations living in lead-laden environments. We haven't finished the business of taking care of known serious risk factors to the developmental health and well-being of young Black kids in inner cities. So we've got a lot of work to do in risk mitigation, in old housing communities, and really rethinking how we design our communities. But the immediate crisis right now has to be, what are we going to do as a nation around the issue of an urgent need to address the eviction threats that's confronting our population.
We have a question in here. It's actually directed toward one of our panel co-chairs, Lark Huang, but maybe I'll ask the full panel to comment on it and then see if Lark wants to comment as well. And it relates to whether there are mentorship programs to support the development of a more diverse pipeline of mental health and addiction care professionals in the workforce, in addition to our public health workforce. Are there strategies that we are using or should be using to try to build out a more diverse workforce? Dr. Gordon or Dr. Volko, do you guys want to talk about this first, and then we'll see whether Lark wants to comment?
Sorry, go.
I think we're probably going to say very similar things, which is that at NIMH and well, I'll speak for NIMH. At NIMH, our principal concerns are with regard to the research workforce. And we do have a lot of programs to mentoring and otherwise to try to increase the diversity of our research workforce. I can't say that it's been awfully successful, and we have a lot of work to do in this regard. I'm not aware of any efforts that we are engaged with to increase the diversity of the overall mental health workforce. And I'm wondering if Dr. Smedley or Dean Williams might have additional things to say about that.
I certainly do. This is a chronic challenge and it is a symptom of the inequity that we've been talking about. I'm certain that every one of our organizations has a pipeline program. And these are critically important. The American Psychological Association has the Minority Fellowship Program. Very grateful to SAMHSA and NIMH for helping to support these kinds of programs. And they have been enormously successful in ensuring that we get talented people of color into our disciplines. However, if we're not willing to tackle the root challenge, which is that we have deeply separate and inequitable school systems, you know, the very thing that Brown v. Board of Education was attempting to address back in 1954, we will continue to have this question about how can we diversify our professions. We have created separate and inequitable educational opportunities for kids of color. And I'll say it again, segregation is deepening, not lessening in this country. So I'm hoping that we can focus our attention on these structural inequities. To me, school segregation and residential segregation are examples of structural forms of racism that we have yet to have an honest conversation about, and certainly a lack of political will to challenge.
We are in a moment when trust in science is lower than we in the scientific community would like to see. Dr. Smedley, you talked about the role of faith leaders in protecting the mental health of individuals living in communities. So the question here relates to pick up on that theme. Where should we be looking outside the scientific and medical community to help us connect as communicators and to, as folks interested in improving the health of our populations, to get outside our traditional roots to combat both pandemics that we're talking about today?
Sure, I think that was directed at me, so I'll just say a couple words. I don't want to monopolize this, but yes, absolutely. There are many trusted sources in communities of color, faith leaders, fraternal and sorority groups, civic associations, community-based organizations, grassroots organizers. These are all groups that are critically important. It's been encouraging to see that the scientific and research enterprise is increasingly partnering with these stakeholders as a part of our effort to do better community-engaged and community-informed research. So that's a critical first step. But particularly in these times of pandemic, and given the vast amount of disinformation, false information, alternative facts, we have to turn to these trusted sources to provide accurate and timely information to these communities. So I see the scientific and research community increasingly recognizing the power of these kinds of partnerships, and would love to see even more incentives for this kind of collaboration.
Colleen,
I would just add to that how critically important it is. And while it's not the specific focus of today's conversation, the issue around vaccine hesitancy and mistrust in vaccine safety and efficacy in Black and Latinx communities is critically important that we get it right by reckoning with the past traumas that these communities have experienced, that we acknowledge with great transparency that, you know, these traumas are real, and address them head on by having trusted community partners engaged. And often those community partners are going to be those that were listed and discussed before, but also the very underfunded public health, local public health systems. They need to have the talent and the resources to re-engage around the trust in science and the trust in vaccines in their communities. And physicians, the small number of Black and Latinx physicians who practice in communities of color need to be supported and enabled, because ultimately they are the most trusted in their community around vaccine efficacy and safety right now.
And I also want to add too, in the notion of another community that requires attention to bring them to create trust is those with a substance use disorder. And from surveys, I mean, what has happened here is you have a crisis that was triggered by really very nefarious practices of pharmaceutical industry. So there is an enormous amount of distrust among individuals in the substance using communities. And so the concept of here, you have to take these medications that actually in many instances trigger their current situation is one that needs to be addressed explicitly. So it's not just the lack of trust on the government, but it's also a lack of trust in in the pharmaceutical industry.
I mean, I just want to add in one particular program that's very relevant here, and I see Larka wanting to get a word in. I'm sure that SEMSA has programs they want to mention as well that are directly relevant. NIH just launched actually a $500 million initiative to try to understand and mitigate the reluctance to get testing in underserved communities. And these are all community-based projects with community-based partners of all types, from barbershops to colleges that serve minority communities and everything in between. And so I think the research has a very well-defined role in trying to understand the best approaches to counter these well-founded historical reasons of mistrust of the medical community. We've had a lot of success in this area, in the area around HIV testing and care. And so our institute is working with other institutes. We have a long history at NIMH of studying impediments to care and to testing for HIV. And we're applying that and the partnerships we've developed in that regard directly to these issues of vaccine. So we're hopeful that this will actually have a short-term impact.
Lark, do you want to jump in here?
Sure. I wanted to, first of all, this is a tremendous conversation, and I'm so pleased and thankful to the National Academies for letting us pivot to this discussion. I think that we've really looked at the impact of a dual pandemic of racism in this country, as well as COVID, and really uplifted the impact of this on mental health and substance use. I think we already have a shaky mental health and substance use system in terms of how accessible it is to all populations. And I think that I want to go back to the question that was directed toward me, and I'm not quite sure why it was directed to me, but the stigma issues in many of our communities of color also interfere with the pipeline into those professions. And that we need to do a lot more. I agree with Brian in terms of the inequity in terms of educational opportunity in different communities of color, but we also haven't really done a lot of good reach out early on to what mental health means, what substance use is. We've incarcerated people in those communities for substance use. They need to know that it's an illness, or it's a disease, or it can be, you can recover from it. So we need to do a lot more education. We do have programs at SAMHSA that have been pipeline programs, but they're not huge programs. It's not where we have a huge amount of investment. We also, I think, need to identify better the assets in communities of color, that we need to be part of critical coalitions. There are incredible assets that have grown up because they were not served. I have a network of 1,100 community-based organizations, multi-service organizations, but also with a focus on mental and substance use, because the needs of these communities were never served back in the 1960s, 1970s, 1980s. So those are trusted entities. They're not always advertised as mental health or substance use treatment centers. They're multi-service centers where there's tremendous amount of housing support, employment support, but mental health and substance use treatment support as well, which often, if you're leading with how can I enroll my child in Head Start, they may also get them into mental health treatment. So I think we have to identify those assets, because that's also where we'll find people to get in the pipeline for changing the complexion and the face of who are the providers in mental health and substance use. And people go to people who they trust and who also look like them. And I think we can't underscore the importance of that type of connection to really improve those dismal statistics that SAMHSA puts out in terms of high need for mental health and substance use, and very low access, particularly in communities of color. So I just wanted to add that. I don't know how much time we have left, Colleen.
I think we're out of time in terms of additional questions. Thank you to all of our audience members. We had such a great turnout for this forum. And thanks to all of you who put questions into the chat. And I think, Lark, I'm just gonna kick it right back over to you to thank our panelists and to end today.
Okay, so as on behalf of the Planning Committee and one of the co-chairs, we pivoted to this topic midstream through our forum on mental health and substance use. In June, we said we can't not attend to what's going on with the pandemic and the intersection of the pandemic with mental health and substance use issues. We couldn't ignore the taking the lid off of the deep-seated racism that's exacerbating mental health, substance use issues, and really drawing a line between life and death in the COVID for communities of color. I want to deeply thank our 4 presenters. You couldn't have captured this better for us. We're at a very challenging point in our country. I think you've given us things to think about, challenges to take on. I hope we'll get involved in some different kinds of projects that will be really putting an action agenda to this. I think the COVID pandemic has lifted and highlighted the pain of the deep racism in our country, which is so critical to all of our health and mental health well-being. So thank you very much. I want to thank the participants who stayed on with us for this particular webinar, to let you know that we have 2 more webinars, and in some ways they follow on what the discussion that was said today. The second one is going to be looking also more at what's going on in specific communities of color and what are some community-driven and community-based interventions going on. And the third will be looking also at the healthcare workforce and the impact of COVID, the impact of the structural racism in the healthcare system, what that means for our population in general and our community of color in specific. So please register for the next 2 parts of this virtual workshop. Thank you again to the Planning Committee, thank you to the National Academies for supporting this. And was there anything else I missed? Colleen, Caitlin? I think that does it.
That does it. Thank you to all.
Thank you all very, very much.
Everyone.
Thank you.
Bye, thanks a lot.
Bye-bye, thank you.
Thank you, everyone.
Thank you.